Okay. No bad.
All right, so I guess send me the link afterwards because I suppose I'm the facilitator.
Yep.
Wonderful. So I'm Jared Smith. My project's on improving opioid safety, and I live in Corvallis, Oregon.
Wow.
Do we want to do, I've got questions 7 through 9. So those questions are who you are, where you're from, what kind of practice you're in, what kind of
Gotcha.
area you're in, and then maybe add if you're a nurse practitioner or nurse midwife. But my name's Callie Crouch. I live in the Texas Panhandle. I'm a family nurse practitioner. I work in an outpatient clinic. And my project is on obesity management.
I'm Becca. I am in Williamsport, Pennsylvania. I'm a midwife, and my project is obesity and depression and increasing exercise to manage them.
Do you work in rural, urban, or suburban?
Rural.
Me too.
My name's Ardith O'Rourke. I'm from Western Kentucky. I'm a family nurse practitioner at Alliance Cole. And my project is anxiety and depression screenings.
I'm Andy Liu. I live in Wyoming. I'm a nurse midwife. I work at a federally qualified health center and doing women's health. I'm not doing any full scope OB right now, but I'm doing my project at the hospital. I used to deliver babies, and I'm doing postpartum hemorrhage preparedness in the rural setting.
Very good.
Okay.
All right.
Okay, Rebecca, you want me to go ahead and start with the questions? You're filming, correct?
Well, Jared's a facilitator, I guess. So.
Oh, okay.
Who has questions 1 through 3?
1 through, okay. I do, Ardith O'Rourke. At my place, I'm from Kentucky, and we go by, first of all, we do have a job description, but we go by the State Board of Nursing. We have a scope of practice, and I will share that with you all here if I can, because I thought that, well, no, wait a minute. Okay, let me share. If I can do this right. Okay, I thought this was real. Can you all see this?
Mm-mm.
No? What did I do wrong? Okay, I hit the, oh, wait a minute. Okay. I better hit the share button, hadn't I? Oh, well, see. Here we go. Can you all see this now?
Yes.
Okay. The Kentucky Board of Nursing, it's a 6-page scope of practice. So I thought the very last page was the best because a lot of times am I able to do this, or can I do this, or should I do this? So this is kind of like a guideline here. You ask yourself, and then you can go back to the other 5 pages and you can find out your answer, what you're eligible to do. So I thought that was really neat. They've just added this here recently. So if it just gives you, if you're having a hard time deciding if you can do a treatment or if you're stepping over your boundaries. So I will stop sharing this right now. Okay, let me get this back down. Okay. In my office, I'm a family nurse practitioner, like I said, but in my office, we perform initial patient screenings, patient history, physical exams, and we're big on new hires. And every year we do health risk assessments, but we incorporate them in the physical exams if they're new employees. And then we update patient records, and we check the records for accuracy at each appointment. But we have just now, we're kind of old school here. We're a small clinic. We just this last year went on electronic records. It's a program called Dr. Chrono. But I still keep paper records in my clinic due to the fact that if the wind blows the wrong way, we are out in the middle of nowhere in a subdivision, and our internet is just, we might have it one day and we might not. So I don't mind keeping paper charts. And then when we do our HRAs, health risk assessments, we analyze the data and check their labs and see if they need to have follow-up treatment or if we need to prescribe. Family nurse practitioners in Kentucky, we have to have a CAPA with our employer, and we can practice independently, but we have to have a CAPA if we wish to write scheduled drugs. And they have a House bill right now. They're trying to 132. It goes February 19th for the vote to see if we can do away with our CAPA. I don't know. They've tried it several times, and the docs, keep, cutting their knees out from under us. But we'll see. It probably won't pass this time either. I don't know. But we have to, in our office, we have to have ACLS certification. We have to have the BLS certification. We have to keep that up. And we're a source also, besides, writing labs, making doctor's appointment referrals for colonoscopies or physical therapy, and things like that. We also serve as a resource for our patients if they need to find something more out about a condition they may have, or we will look it up and we will do a discussion one-on-one with this patient to make sure they understand it. And if not, we get them to the appropriate people, doctors, or like I said, physical therapy, wherever they need to be, we get them to them. And let's see here. We prescribe medications. We try to give them the best care we can. We monitor if the interventions that we give them, make sure we follow up care with them to make sure they're okay. And then we collaborate with the local hospitals. They have certain places, their insurance is 100% paid. So we try to send them to those facilities. We've got them from West Virginia to Tulsa, Oklahoma. They have a lot of choices, but we collaborate with them to get them to the best possible care that we can. And on the, let me see. I'm going to share something with y'all again. Forgive me. Okay, on the quality improvement survey. Well, let me see. I got to hold on. Let me share. I'll learn this one of these days, y'all. Okay, here we go. Here's do APRN providers at the job site have a description? And for everybody who answered, almost 84.5% said they do. And I know mine does. Like I said, we go by the Board of Nursing first, and then we have other qualifications we have to do. And then if yes, the APRN job description forms basis for an annual employee performance review. That's 63.70% said yes. For me, my boss, he does that. We have a meeting every year in Lexington, which it'll go with this one, a medical conference every year. And we have like 9 mine sites, 9 clinics in 7 or 8 states. I'm not sure which, but we go through everything for the whole year, what has changed. We have great IT people that when anything new comes through, if someone asks a question, they will send it out to everyone so we'll know. And then at the end of the year, we go up and we discuss this, and our boss does. If we get a raise, that means we've done very well and on the annual performance. And I've been some years we haven't gotten raises. So right now we're doing pretty good. And now include peer review. We don't, my boss doesn't have that. It's his business manager, the attorney, and him. Like, we're a small company. So we don't do the chart audits or reviews. and we do involve the sit down discussion and what we're going to do, what we have coming up for the whole year, the next year, what the company the changes that the company are making. So does anybody have any questions or anything that I can answer? I'd be glad to, if I can answer them.
So with only 84% of the APRN providers having a job description, would you recommend that the remaining 15% or 42 nurse practitioners or advanced practice nurses have a job description?
Now, see, I don't know. That's come off that monkey survey. I really don't know. I've never worked anywhere that didn't have a job description, and like in Kentucky, we have to go by the State Board of Nursing, the scope of practice. So I don't know where those 42 came from. I mean, I guess, some states, I guess they have their independent. They don't have to have any CAPA with a doc or something. I guess, I don't know, but I'm not in one of those states, so I have no idea.
Doesn't preclude a job description.
Yeah.
So, I mean, how about the rest of you? Do you feel that, would you work somewhere if you did not have a posted job description?
So my clinical site doesn't have a job description. They just barely started hiring APRNs. They were very against the physician's wills. So we're an independent state. The physicians don't like that, so they really try to keep their thumb down on hiring any nurse practitioners at the hospital, especially if they're in any kind of competition. They just changed the bylaws so that CRNAs cannot practice independently in the hospital, so that they're not hireable. So we'll see if they get a job description.
Yeah. Where I'm at, our board is like really vague with what our scope of practice is. So, I mean, the position you work with kind of determines how much autonomy you can have. But like, we have a job description at work. It's really vague. And the nurse practitioners know what they can do, but it doesn't help anyone else know what we can do. Our human resources department still doesn't know what I do at my job. So I don't know if it even matters that we have a job description.
In midwifery in Wyoming, like when I went to apply for my license, at the State Board of Nursing, they were like, "You're in the wrong place. You need to go to the State Board of Pharmacy." And not State Board of Pharmacy, sorry, the State Board of Midwifery, which governs lay midwives. And that was, I mean, nobody really knows what midwives do here. So
they don't know what midwives do down here either. Like, I'm not a midwife, but I did clinicals with a midwife, and she tried to work like in the bigger city that's closest to both of us. They won't hire midwives there. Even the people that are here, I ask, would you use a midwife? And they don't even know. They think that means you're going to have your baby at home and nobody's going to be there. No one's going to know what to do if there's an emergency. Like, they have no idea that midwives deliver in hospitals. That I'm like, it's just completely different than using a lay midwife, but they have no idea what midwives do here.
Would you say that underscores a lack of general knowledge that the public knows what you're able to do?
Oh, definitely.
Yeah. I had to do this interview, and this guy asked me in the middle of it, just like throws this question out that we can do anything a doctor can do. Well, in the state of Texas, you definitely can't. And I was like, oh my gosh, you boxed me into this corner. I have to figure out how the heck to answer this question without insulting every doctor in the area. I was like, no, I'm not a doctor. It's not the same thing.
All right. And should there be a uniform job description throughout? Like, would you like to have one for those states that don't, or people who don't?
I think every state's so so different as far as how we practice, and so if all states became independent, I think it would be a lot easier to create a more across the board job description.
I think so too, because I mean, you can get into some pretty hairy situations, you know. So I think they should have.
All right, we're going to welcome Jennifer.
You're muted, Jennifer.
I had trouble getting on this morning. I apologize. I don't know why it wouldn't let me on.
And I believe you're up next if everyone is satisfied with questions 1 through 3.
Yeah, I'm good.
All right. So, Jennifer, we'll start with you. Question 4. Does the practice participate in a data registry for benchmarking?
No. Our practice is small. It started with just one physician by herself, and she left another practice to kind of go off on her own. So she's trying to get her feet from under her and brought me into the practice. So that's something I brought up to her recently. But right now, nothing at all. And she's going to be bringing a midwife on as well. I'm women's health practice just in the office. So I suspect when we bring the midwife on and we kind of gel a little bit better and we're expanding physically, I think that's probably going to come into play at that time. But right now, no.
We've talked about doing it, but we just haven't actually done it yet. I think it's a cool thing to do. I think we should, but we just haven't done it yet.
We don't do it at my place. We're small.
The hospital where I'm doing my clinicals, they have a great quality department. They're trying to improve, but it's nurses who run quality and physicians who butt heads with them all the time. So so it's a difficult job for them because they can't seem to improve process without jumping through massive hurdles.
We do benchmarking, but they're not very good about sharing the data with you. And then when they do share any kind of data, it's like, all right, fix this. See you later. So
Similar, our practice does not do any type of benchmarking. So it looks like only one of us had benchmarks. If the practice participates in the data registry, does it do any of the following?
No, I know we don't do any benchmarking with ACNM.
Okay. But do they report it to the healthcare team or the community?
They recently did one with the community, and the healthcare team at our facility there's always the benchmarking stuff that is posted in the faculty in the nurses lounge, so they can see it. I think the most recent one was hand washing, and it was pretty good.
Good. So, would the recommendations be that all practices participate in data registry for benchmarking?
think it's always helpful information, and you can always see, you know, that's how you see a lot of improvement, I feel like.
I feel like yes and no, because I feel like in our practice or in my facility, even when you look at other hospitals that they own, like they'll say how great they are at all this stuff, but working there, they're not at all. They just do the paperwork right, and it really isn't a good, I don't know, depiction of what they actually do. So we look really good on paper.
All right. And then it still looks like we have question 6 to discuss. Describe your experience of witnessing the following skills to support improvement relating to the human side of change at your clinical site. So, how often do people do team meetings or model behaviors that reflect active listening or handle difficult conversations when individuals express an opposing view?
Well, I'll tell you, I'm one of the people that says that I never see this where I work. We have a meeting about every month that's basically just a bunch of announcements, and that's all. Never been to a team meeting with like an agenda, and I've sure as heck never been told what the meeting's about before I got there. So we don't have great team meetings, and we don't really talk about how to improve quality where we work. So
we have pretty good meetings every 3 months with the OB department, and then we also meet with the PEDS department. And then 4 times a year we have like a big meeting with everybody in the, I guess I don't know, all the providers in the practice, like everybody, like all the doctors in the hospital, which is pretty cool too.
We just had for the team meeting assignment, I organized a staff meeting with the OB nurses, and it really went well. We got a lot of things hashed out. They have a new OB director who I feel like is really going to be good. The leadership has been very, very poor on the unit for probably the last 4 or 5 years, so the morale is really, really down. So I'm doing biweekly team huddles for my project, but it's hard to get everybody on the team when they're not working. So I'm just I randomly will drop in and just find out like how things are going, and then if we can, we kind of have a little huddle and discuss. And they're pretty happy with my team's been really good at about doing and carrying out my project, so that's been really nice. But it's been a lot of team. They're really trying to improve morale, and so that seems to be happening, which is good.
Our practice is so small physically and staff-wise, but now we're growing. But so the meetings didn't happen at all when I came on because we could just easily like holler at the front office or talk, back and forth. But now we are gelling and we're meeting more regularly. We're addressing a lot of problems. And I don't think my doctor would want to admit it, but with me doing the project and I'm doing debriefs and things like that, it's kind of fostered that environment. And even just 2 days ago, she actually took us out to a restaurant at lunch to have a meeting. And so I see the trend getting better on our end. And plus we are going to be growing, adding staff and everything. So we're going to have meetings like this. So it's improving. It's gone from 0 to something now at our practice. I think that's going to be really good.
Same way at my practice. We're very small, and we never did do meetings until I started this project. But I mean, because I'm like, Jennifer, we could just, we're just right all in one little, 3 little rooms here. You can just holler back at each other. But I do see that having the meeting, I do like that. But now for the company-wide, we just have one meeting a year. It's usually late September, early October in Lexington. And then we go through everything for the whole year. We do our OSHA requirements, our MSHA requirements, and talk about everything through the year, even if like I said earlier, our IT people, they're great. Anybody has a question, they send it out and everybody will know we have the information, and then when we're all together, we can discuss it. But we don't have, meetings regular until I started my project. And I do like that. Keeps us more involved. Because one of my staff may think of something else that we could do, different ideas coming up, so I do like the meeting.
For my project, it was kind of difficult. Well, I am doing inpatient OB, so it's different than office. Because like in the clinic that I work at, we have morning team huddles, but it's difficult to get everybody together just because everybody works different shifts. Day shift, night shift nurses, and weekend nurses, and PRN nurses. So that's been kind of a challenge.
I think having formal meetings makes it where you're a little bit more focused on what you need to talk about. Like talking, because we're a bigger practice, but everybody has a pretty good relationship. So you can go and say, hey, you need to do this or you need to do that. We're not doing this well. But I feel like when you actually sit down, know what you're there to talk about, you can actually stay focused and get a lot more done.
Very good. Well, is everyone ready to move on to questions 7 through 9?
Questions 7 through 9 are mine, and those are the ones that are just who you are, and where you work. They really should have made question 7 through 9, question 1 through 3, I think.
Certainly. Well, now that Jennifer is back, I suppose we can go through that again. So, and I never fully gave you what I do. So I'm Jared Smith. I'm a family nurse practitioner. I live in Corvallis, Oregon. I currently work in an outpatient, suburban, I guess, interventional and chronic pain management. And my topic is on improving opioid safety through the increase in identification of opioid-induced side effects. Next.
My name's Ardith O'Rourke. I'm a family nurse practitioner in Western Kentucky for a local coal company, Alliance Coal. I have a very small office. My patients are the coal miners and their families. We don't have to do insurance or anything like that because they have their insurance. We just have to get them to the proper place where they need to go to get, whatever treatment. If it's something that I cannot take care, x-rays, MRIs, they have contracts with hospitals across, like I said, about 8 or 9 state area that they can go anywhere. And so we collaborate with them to get them to where they need to be.
I'm Becca Russell. I'm a midwife in Williamsport, Pennsylvania, which is a rural community, and I work at a community-based hospital.
And I'm Callie Crouch. I work in a rural area at an outpatient clinic, and I'm a family nurse practitioner.
I'm Mandy Liu. I'm a nurse midwife in a rural community in Wyoming, and I work in a federally qualified health center, but I'm doing my project in rural or in inpatient OB on postpartum preparedness in the rural setting.
I'm Jennifer Carter. I'm a women's health nurse practitioner in a suburb of Dallas. I'm working at OBGYN office, and my project's going to be, it is on obesity care in the women's healthcare setting using shared decision-making tools.
Very good. That's everybody, I think.
How would we make a recommendation about this?
Has anybody ever worked in like 2 different settings, like worked in an outpatient clinic and in a hospital, or worked in a rural area and an urban area?
I worked in last year I worked for a private practice. And I had hospital privileges, and then she couldn't afford to pay the nurse midwives anymore, so she dissolved the practice. And then I went to the federally qualified health center, and then my partner, she's a nurse midwife, she went to the hospital, but she's been practicing for 15 to 20 years, so she had a really strong patient base. So they took her solely because she was a moneymaker. So, but the providers, the OBs, are really upset about it. So I'm happy where I'm at. I work Monday through Thursday, 8 to 6, no call anymore. So I'm not complaining.
I've always worked rural, so I haven't worked both in urban or I'm just rural.
Still at my first job, so still just outpatient.
Me too. Well, are y'all ready to move on to the last couple of questions then?
Sounds good.
10 and 11 is me. Please identify the category that best describes the clinical care model where you're conducting your DNP project. So in my project, it's a combined practice model. The nurse midwife takes the same patients as the MDs, and then they manage if they need to. She doesn't turn them over to OB care. She'll, like if they're preeclamptic, she'll manage the labor part, and they'll help her manage the the medical part of it.
That's how ours works too. It's a combined practice model, and the doctor is always on call with us if we need them for any reason. And then they see the same patient in the office depending on what they need, if they need set up for a C-section or whatever their case may be.
Same here. We're a combined practice model. Most of our practice is nurse practitioners, though. So, but we've got a couple of physicians because we have to have an overseeing physician here. So.
Mm-hmm.
At my place, we have a doc comes in from Tulsa every month for 3 or 4 days to see patients. But my boss, I can always he's in Lexington. So like I said, we work independently here in Kentucky, but as long as I can get a hold of my boss by phone, we're good to go, if I need him. And Dr. Bo Axelson comes out from Tulsa every month here about 3 or 4 days.
We also have a combined model of practice with the physician and myself for now. And she sees any patient that I obviously can't see for surgical consults and surgery, but we both take care of OB and to the point of high risk where I need to turn them over at that point. And then she does all the deliveries, of course.
In Oregon, we can practice independently. We are a combined practice model. Outside of the interventions, which my business owner, the doctor, does, but I do order a lot of those interventions for him to do.
Wyoming is really good. It's really a good place to be in because we have really pretty much independent practice, and so to open a birthing center or anything would be ideal. So that's kind of a thing that we've been tossing around here. It's just there's just politics, which I'm sure every place has politics. So I think that's the frustrating part of when you're like, I was a nurse on OB for 12 years where I'm doing my project, and so it's kind of feel like the OBs just are worried more about like monetary things than actual patient care, and what the patients really want is a little frustrating, I feel like. So I don't know if the nurse midwife at the hospital now has as much support as she felt like she has had in the past from other physicians.
Okay. Would you say that the combined practice model is a recommended model, especially in states that allow independent nurse practitioner practice?
I think it's a great model if you can make it work. I think it works out really well. I think the patients are, especially in midwifery, patients a lot of times want to have a midwife, and it's nice to have, they can have their continuity of care with their midwife, even if something happens. I first assist with cesarean, so that was nice when my patients had to go to cesarean. I would go, all the way through with them. And the way we were here, we have our own patients. It's not a big practice, so so we were able to follow our own. And I think it's a great model for patient care.
Our competing practices in our area are all the same model. And so our population is used to that and they respond to that. So I think that for where we are in our demographic, that it just works really well, that we're all very congruent. Every practice is just a model of each other, almost an extension of each other. So, and we've gotten transfer patients in, and it just works out really well. So I think it's a very good model for where I am in Texas.
I think that it's a good practice to have, but it can be very limiting depending on who your overseeing physician is here. So you can have a physician that's like, practice good medicine, call me if you need me. Or you can have someone who writes out the protocol for every single thing, how you're going to treat it, everything. They can totally micromanage you, or they can say, you're good, call me if you need me. So just depends.
Pennsylvania is not independent practice, but working with the doctors that we have, they're all pretty great, and they let us kind of manage things as long as they feel that it's appropriate, and they check in, twice a day, and unless we need them more frequently than that, and they're always there and helpful in case we need them. So I think ours works out really well for us.
Ours really works well. I mean, if I need to call my boss, I do. And if not, he lets us, we work freely. Then if I need to call the one in Tulsa, I can call the one in Tulsa, so I've got several choices, but it works well here.
Are we ready to move on to question 11?
Sounds
let's
good.
state one thing you've learned about quality assurance and performance evaluation during this experience. I feel like I've worked a lot with the quality department at our hospital throughout this project, and they've been extremely, extremely helpful. They're happy that I'm doing the project. It really took a lot of weight off of the new director's shoulders, because I created, we're doing simulations in debrief, which is, we've never done simulations before. So I'm doing 4 postpartum hemorrhage simulations, 1 in each PDSA cycle. And they have been successful. I was able to get all 4 providers on board. And so each provider has attended each of the simulations. But the quality assurance part, she was able to make it a competency. And so then quality has put it into that it's for quality improvement for the whole hospital. So, but it's a lot of work, and I had no idea how hard it was to, or how stressful I guess it would be to do it all, because I feel like when you take a test or when you're getting your master's and you're learning like anatomy or something, you can study and you can control, kind of have a little control. And this, I've just felt completely like out of control, and it's hard to let that go, I feel like. Performance evaluation. they're changing the whole performance evaluation system right now. In the middle of that, their quality is actually helping to revamp that. So I know that they're revamping it, so there wasn't like a straightforward answer for that.
And the way we do our performance evaluation and the quality assurance, we do actually pretty well with all the different things that we evaluate for. So that was kind of nice to learn that. And then I just thought the ACNM benchmarking is something that we should look into more. I never really thought about it much, but I think that would be something that would be neat for our practice to do.
I've just learned that I didn't know anything about doing quality improvement. Like the only exposure I've ever had to quality improvement is someone showing up and saying, "We're not doing well at this, do better." And that's it. That's the most quality improvement I'd ever been exposed to. And it's been a little bit stressful doing the project because I feel like I'm really alone because they don't really do quality improvement. So there's no one there that does this that you can call and say, I don't know what the heck I'm doing. So I had to get used to really taking advantage of having my instructor that I can call, which was hard for me. But I just learned that I've never really been exposed to true quality improvement.
I just remember when quality would come around and you're like, oh no. And now it's like I'm that person.
It's been a challenge for me. I don't know about the rest of you, but coming from the hospital setting, there was quality improvement left and right, up and down all the time for years. And then I've come to the small private practice setting where there was zero. And so I kind of asked to implement by kind of reviewing my personal medical assistant who has been there for her 1-year anniversary. So I kind of modeled that by sitting down with her and reviewing some things. And then with our debriefs that we do, we have found a lot of holes in the practice that, you know, they're not doing with the patient as far as just their rooming and checking in patients. And so I've been kind of doing that where the doctor's kind of seeing it on the fray. You know, so I think that's going to be a model that's going to come into practice, especially, like I said, we're adding more people, another medical assistants coming in, another part-time practice. So hopefully that'll kind of dribble through from what I've learned from the hospital all these years and what I'm implementing with the project. So it kind of started small with just me and my medical assistant, and then hopefully it'll bloom from there and then not go backwards.
I agree on what Jennifer says. It's I come here and we just don't, you know, it's just small. You do your job and you just go home at the end of the day. Until I started doing this project and really getting into it, and we incorporated the anxiety and depression screenings in with our health risk assessments, I was really surprised, you know, because and when our GM came back to have his done, he said, you know, he said, that's good because he said, you don't know. And we've got we have a psychiatrist on staff that these people can see if they need to, but we didn't have that many until I started doing my project. And now people are opening up to that idea. You know, maybe I just need to talk to somebody 15 minutes or whatever. You know, he talks to every person 15 minutes when he has them. So some go on medication, some don't. So this has been a good thing, and I hope this continues after this program is after I'm finished in my project.
Like a lot of other small clinics are, and the clinic I work at did not have any quality improvements before this project started. We rarely had quote unquote monthly provider meetings. However, now that we have started, we have one of my interventions is every week sit down provider meeting, quality team meeting, and then they have been adding on monthly provider meetings for case reviews and such. So, does anyone have any questions overall or comments about the rapid fire quality assurance and quality improvement session?
Jared, I'm like Callie. I think they need to put the questions that she had. I think they do need to go at the top of the survey, you know, because that was a little backwards. Because actually we were just doing it double, you know, but that's a good thing too. You know, I'm glad I've met everybody, and it's really interesting. Everybody was from a different place. That was really neat. But I think Callie's questions, just the one she had, need to go up top survey. Whoever made the survey out, I don't know. They didn't ask me.
We still have a few minutes. So Ardith, or who's going to be sending me the time link?
Rebecca is.
I will. Yeah, I switched with Ardith, so
we switched.
Perfect. As we've been going through, I've been typing out the summaries on the questions 1 through 11, and then I believe it's only supposed to be a half page. I'm assuming single spaced, I hope.
And then you send us that in the link.
I will send you that and the link. But if it's okay with everyone, I just sort of like things double spaced. I'm going to type that up and send it to you guys later today.
Sounds good.
That sounds good.
Excuse me. All right. So, anyone have any closing remarks? Quality assurance is a good thing, and it should spread, and so should independent practice and nurse practitioners.
Agreed.
Yeah, me too.
All right, if you guys are done, I'll stop the broadcast and I'll send you the link, Jared.
All right, I believe we have approached a little over 45 minutes, so I think that is our time.
Okay.
Okay.